Our presentation today will follow this agenda. After I provide a brief introduction, Dr. William Gruber, Senior Vice President, Vaccine Clinical R&D, will review the booster clinical development program, including the neutralization data from Phase 1, the Phase 3 immunogenicity and safety results, the pharmacovigilance plans, real-world evidence supporting the use of a booster, and a benefit-risk conclusion. After this, I will come back to provide conclusions for our presentation. The Pfizer-BioNTech COVID-19 vaccine, also known as BNT162b2, has been available for the prevention of COVID-19 disease in individuals greater than or equal to 16 years of age since December 2020 under an emergency use authorization, and in individuals greater than 12 years of age since May 2021. To date, 1.7 billion doses have been distributed globally. Between February and May 2021, and in accordance with FDA guidance, we conducted a pivotal clinical study to evaluate the safety and effectiveness of a booster dose. FDA granted full BLA approval of BNT162b2, also known as Comirnaty, on August 23rd for the prevention of COVID-19 disease in individuals greater than 16 years of age as a 2-dose series given 3 weeks apart. The duration of protection following the 2-dose primary series is currently unknown, but available data suggests that efficacy wanes over time. Based on the positive results of the booster dose study, available real-world evidence, and in consultation with FDA, on August 27th, we submitted a supplemental biologics license application to seek approval of a single booster dose after the primary series. There is substantial randomized controlled trial data and real-world evidence to support that vaccine efficacy wanes over time. As you heard earlier, recent data from Israel and the United States, in the context of the Delta variant of concern, suggests that vaccine protection against COVID-19 infection wanes approximately 6 to 8 months following the second dose. A retrospective real-world evidence cohort study conducted at Kaiser Permanente, Southern California, suggests that the observed erosion in vaccine effectiveness is likely primarily due to waning effectiveness rather than due to Delta escaping vaccine protection. Waning effectiveness over time is further supported by a recent FDA-requested post-hoc analysis of breakthrough cases in the pivotal Phase 3 efficacy study. To demonstrate the safety and effectiveness of a booster dose against COVID-19, Pfizer and BioNTech conducted a sub-study of the Phase 3 pivotal study that complies with the FDA guidance. The results of this study demonstrate that a booster dose of BNT162b2 has an acceptable safety profile and elicits robust immune responses. Finally, real-world evidence from a recently initiated booster vaccination program in Israel that we just heard, in the face of waning immunity and in the period when the Delta is the dominant vaccine, shows a booster dose has a reactogenicity profile similar to that seen after receipt of the second primary series dose and restores high levels of protection against COVID-19 outcomes. The booster study was conducted in individuals 18 to 55 years of age, as recommended in the FDA guidance. The study was conducted in 2 phases. Phase 1 demonstrated that a booster dose administered approximately 6 months after the second vaccination of our vaccine had an acceptable safety profile and elicited robust immune responses against the wild type as well as the Beta and Delta variants of concern. Phase 3 showed that the vaccine was as well tolerated as the second primary dose and elicited immune responses against the wild type variant that were non-inferior to the immune responses observed after the second primary dose, meeting the protocol-specified immunobridging success criteria for GMTs and seroresponse rates. Moreover, and in accordance with FDA guidance, the safety and effectiveness of the booster dose in individuals 18 to 55 years of age can be extrapolated to individuals 16 and 17 years of age and over 55 years of age. These data serve as the basis for the supplemental biologics license application. During the remainder of our presentation, we will share data with you that demonstrates that the overall benefit-risk of the booster dose is favorable. Specifically, that the demonstrated safety and effectiveness of a third dose support adding a booster dose to the vaccination schedule. And the global real-world evidence demonstrates that the reduction in vaccine efficacy is likely due to waning effectiveness and supports that a booster dose can restore high levels of protection with an acceptable safety profile. Based on these, we're requesting licensure of a single booster dose of BNT162b2 administered intramuscularly at least 6 months after the primary series in individuals greater than 16 years of age. I will now turn our presentation over to Dr. William Gruber, who will present clear and compelling data demonstrating the booster safety, immunogenicity, and effectiveness. Bill?
Thank you, Donna. It's my pleasure to share with you today the clinical program that supports the safety and effectiveness of a booster dose. I have 3 goals in my presentation this morning. First, I will speak to the public health need that could be well served by a booster. Second, I will describe the clinical trial and real-world effectiveness data supporting the safety and effectiveness of the booster dose. Third, I will conclude with overall benefit-risk of a booster dose. Let's begin. There is clear erosion of vaccine protection over time against COVID-19, and emerging data indicates loss of protection against hospitalization. We need to maintain high vaccine effectiveness against COVID-19 to contain the pandemic. A safe and effective Pfizer-BNT vaccine booster dose for individuals 16 years of age and older would be expected to restore protection and reduce COVID-19 illness and spread. The BNT162b2 vaccine is highly protective against COVID-19, but the duration of protection wanes over time. Let's talk about the lines of evidence supporting this claim. First, data from the pivotal phase 3 clinical trial showed that 2 doses of the Pfizer-BioNTech vaccine administered 3 weeks apart confers protection against both symptomatic and severe COVID-19. That, of course, was the basis for the emergency use authorization and the recent licensure of the COVID-19 vaccine in individuals 16 years of age and older. The full duration of protection of the Pfizer-BioNTech vaccine is currently unknown. An analysis of efficacy up to 6 months after dose 2 from the pivotal clinical trial shows that initial vaccine efficacy slightly wanes over time in the pre-Delta period from 96.2% in the first 2 months after vaccination to 90.1% over 4 months, and is still sustained at 83.7% up to approximately 6 months. Further waning of immunity and protection over time has been observed across the world, coinciding with penetration of the Delta variant. Originally observed in Israel, as you heard, this is now being observed in the United States and elsewhere. As we all know, the Delta variant became widespread globally as of June and July of this year. Reports describing reduced effectiveness of the Pfizer vaccine and other COVID-19 vaccines against SARS coronavirus 2 infections caused by Delta have surfaced from Israel, the United States, and Qatar, as you've also heard earlier this morning. Recently in Israel, reduction in vaccine effectiveness has been observed against hospitalization and severe infection over time after a 2-dose Pfizer vaccine primary series. And again, you heard details about this earlier today from the Israeli Ministry of Health. In addition, recent U.S. CDC data hint at reduced COVID-19 vaccine effectiveness over time against severe disease and hospitalization in the U.S. This reduced vaccine effectiveness tracks with longer spans of time between 2 doses of vaccine and SARS coronavirus 2 exposure. Vaccine effectiveness studies to date have not adequately differentiated the impact of Delta from potential waning immunity on recent reductions of vaccine effectiveness. In collaboration with Kaiser Permanente Southern California, Pfizer evaluated overall and variant-specific real-world effectiveness of the Pfizer vaccine against SARS coronavirus 2 infection and COVID-19 related hospitalizations by time since vaccination. This was done to further inform issues of waning immunity and protection. So let's first take a look at the methods that were used in the Kaiser trial that informed thinking. The setting is the Kaiser Permanente Southern California group, which includes over 3.4 million members greater than 12 years of age who would be potential vaccine recipients. The study period includes December of 2020 through August the 8th, 2021. This encompasses both the period when first the Alpha and later the Delta variants were present. Whole genome sequencing has been done on all samples obtained during this period as part of this trial. A cohort approach was used using Cox models. And again, this looks for both outcomes of infection as well as COVID-19 related hospitalization as defined in the footnotes shown at the bottom of the slide. The vaccine status was evaluated with those fully vaccinated with 2 doses of vaccine at least 7 days after the second dose. This also looked at attack rates in the unvaccinated as a comparator. Here's the first key observation. Vaccine effectiveness waned over time against infections, but as of this summer, had not yet waned against hospitalization in the Kaiser Permanente study. So let me describe for you the data that supports these observations. If we start on the left-hand side, you see the graph titled SARS coronavirus 2 infection. On the x-axis are represented months after full vaccination, and on the y-axis, adjusted vaccine effectiveness. Each of the colored lines represents a different age group from 12 to 15 years of age, up to adults 65 years of age and older. The black line represents all individuals 12 years of age and older. Vaccine effectiveness against circulating virus at each time point is shown as a corresponding number above the x-axis. Vaccine effectiveness was 88% in individuals 1 month after 2 doses of the Pfizer vaccine in this study. As you can see, for all age groups 16 years of age and above, efficacy wanes over time, dropping to 47% for those individuals out more than 5 months from completion of the 2-dose series. For 12 to 15-year-olds, efficacy may be somewhat better sustained, perhaps consistent with higher virus neutralization levels achieved in this age bracket. However, follow-up is of shorter duration due to the more recent approval of vaccine for this age group. If we look on the right-hand side, we see, in contrast to effectiveness against infection, effectiveness against COVID-19 related hospitalization has been sustained over this period of time in all age groups from 12 to 15 years of age to those over 65 years of age, out to at least 5 months. You can see that the efficacy for those vaccinated at less than 1 month is 87%, and for those vaccinated at greater than 5 months is still around 88%. Now, please keep in mind what you've heard earlier from the Israeli Ministry of Health. Effectiveness against severe disease and hospitalization has begun to decline in Israel. The combination of early comprehensive immunization and a high proportion of the population more than 6 months post-vaccination in Israel may have contributed to this early signal in Israel. These results, along with recent CDC data, portend that effectiveness against COVID-19 hospitalization and severe disease are less likely to remain sustained in the future in the U.S. We may see similar increases in hospitalizations and severe disease in weeks to months for those individuals vaccinated early in the U.S. campaign. If so, the time to restore protection with a safe and effective booster dose of BNT162b2 is now. It's important also to look at the relationship between vaccine effectiveness and the variants that are circulating. And a second key observation from the Kaiser study becomes clear. Vaccine effectiveness wanes over time irrespective of the variant of concern. What is the evidence to support this claim? Again, the orientation of this slide is much the same as you saw previously. Months after full vaccination are shown on the x-axis, and adjusted vaccine efficacy is shown on the y-axis. Whether we examine other sequenced SARS coronavirus 2 variants, represented by the black line, or the Delta variant, shown in the blue line, the vaccine effectiveness over time wanes. Point estimates of vaccine effectiveness are lower for the Delta variant after completion of a 2-dose vaccine series, but a number of the confidence intervals overlap. Most prominently, comparative data shown here supports that declining immune response over time is the primary driver of vaccine effectiveness and not variant escape. Restoration or improved immune response by a booster BNT162b2 dose would be expected to restore the comparable high protection against Delta and other variants seen at the left end of the graph. We also have additional information gleaned from the pivotal clinical trial that informs this thinking. This type of randomized control analysis was noted to be a best practice by Dr. Stern earlier today. It reveals waning protection between 5 and 10 months after 2 doses of the Pfizer vaccine. As shown in the top graphic, this evaluation was done in the pivotal phase 3 efficacy trial in individuals over 16 years of age who completed the 2-dose series early in the study, the original vaccinees, to participants who were in the placebo group that crossed over to the vaccine after the vaccine received emergency use authorization. This permitted evaluation of the difference in incidence rate and relative protection against COVID-19 for those who received vaccine proximate to the Delta surge, the crossover group, versus those who received vaccine more remotely, the original vaccinees. The text at the bottom, beginning on the left, describes the results. The mean time from dose 2 to July the 1st is 4.7 months for the crossover group and 9.8 months for the original vaccine group, providing a separation in time that allows one to differentiate a potential effect of this parameter on immune response and protection. 90% of the crossover group received dose 2 less than 6 months prior to July the 1st, and almost all in the original vaccinee group received dose 2 more than 8 months prior to July the 1st. Relative vaccine efficacy comparing those immunized later compared to those immunized earlier was 26.3%. If we assume for a moment that protection against COVID-19 falls below 70%, which is reasonable based on trial data as well as the Kaiser data I've shared with you, and that it falls below 70% at 5 months after vaccination, efficacy by extrapolation would be expected to be below 60% at 10 months compared to those that were unvaccinated. Difference in incidence rates calculate as 18.6 cases per 1,000 person-years of follow-up. And the magnitude of this risk highlights the public health importance of time when one extrapolates this to the millions of individuals who may remain at risk in the setting of Delta variant or other variant spread. Over a year's time, 1.86 million more cases might be expected to occur in 100 million individuals similarly exposed over a year who are 10 months out from a 2-dose series compared to those 5 months out from a 2-dose series. A safe and effective booster dose of the Pfizer-BioNTech vaccine would be expected to narrow this gap. So let me summarize then the public health need that leads us to conclude that a safe and effective booster would be beneficial. Israel and the United States real-world evidence suggests that vaccine efficacy against COVID-19 infection wanes approximately 6 to 8 months following the second dose when the Delta variant is predominant. A retrospective Kaiser study suggests that vaccine efficacy reductions are primarily due to waning vaccine-induced immunity rather than due to Delta escaping vaccine protection. Waning vaccine effectiveness is further supported by the recent FDA-requested post-hoc analysis of breakthrough cases in the pivotal phase 3 clinical study. While waning vaccine efficacy against hospitalization was not observed in the United States, this should be carefully monitored, as data from Israel suggests that reduced effectiveness against severe disease could eventually follow reductions in vaccine effectiveness against SARS coronavirus 2 infections. The Israeli experience could portend the U.S. COVID-19 future, and soon. So the information I've presented to you speaks to the importance of waning protection and a compelling rationale to restore protection. What information do we have that reassures us about the safety and potential effectiveness of a booster dose to meet that need? I'm going to share that with you now. First, it is important to understand the nature of responses across not only the current variants of concern, but variants that may be of concern in the future as we contemplate the advantages of a booster dose. For this, information that we have after 2 doses of the Pfizer-BioNTech vaccine are reassuring. The vaccine-elicited sera effectively neutralize a broad range of SARS coronavirus 2 spike variants after 2 doses of the Pfizer-BioNTech mRNA vaccine. And you can see this is true whether we're talking about the wild-type variant, the previously prominent alpha variant, the beta variant, or the more recent Delta variants. I would highlight that even in a circumstance associated with the lowest response seen here, a GMT of 194 to the beta variant, efficacy was observed in the South African cohort from our pivotal trial. You will recall that we demonstrated a case split of 0-9 vaccine versus placebo, 8 of whom had a specimen successfully sequenced to reveal that the virus was the beta variant. So this provides the following reassurances. So far, immunologic escape from serum neutralization after 2 vaccine doses has not been demonstrated. Given that a second Pfizer-BioNTech vaccine dose is associated with robust antibody responses across variants of concern, increased responses to vaccine virus, what we reference as wild-type virus, after a 3rd dose should also be associated with increased neutralization response to variants of concern. I will share with you evidence that supports this logic. First, I want to remind you about the original pivotal study design, which was used for us to examine a booster dose. This slide may look familiar to you because it's similar to what was presented at the time of emergency use authorization. The vaccination period for the purposes of this trial for the 2 primary doses were 21 days apart. As you can see represented on the graph, individuals had active surveillance performed to look for COVID-19 illness in association with nucleic acid amplification test positive evidence of SARS coronavirus 2 infection. As you can see, the length of times that were used to follow up for reactogenicity shown in the green, 1 month for non-serious AEs, 6 months for serious AEs, and up to 2 years for deaths occurring in this population, including older adults and those with comorbid conditions. Now, I want to share with you where we are today. This graphic represents the experimental design of a 3rd dose of vaccine administered to individuals recruited from the phase 1 and phase 3 phase of the pivotal safety and efficacy trial. Again, we took the population who had received their original 2 doses 21 days apart. For phase 1, we went to the sentinel cohorts who were first immunized as part of our trial in May of last year, which represented 23 individuals, and administered a booster dose, obtaining the safety information as well as serum samples to measure immune response over the time periods shown. Lighter blue represents days, darker blue months. After we gained sufficient information from phase 1 that reassured us about the safety and immune response to the vaccine, we then moved to the expanded group that recruited from the phase 2-3 portion of the pivotal trial. So these individuals were now approximately 7 months post-dose 2. There were 312 of them in the group who were boosted, And again, we tracked reactions, adverse events, and obtained blood specimens as shown to monitor safety and immune response. So let me summarize for you first the data from the phase 1 part of this trial. I'm going to begin with the immunologic responses. Post-dose 3, BNT162b2, indicate a substantial boost and reduced gap between the wild type and beta neutralization with the boost. The beta variant was chosen at the time because of concern about potential for a spread and as a surrogate for other variants. So let me now share with you the evidence that supports this statement. First, let's examine the 18 to 55-year-old group on the left-hand side of the slide. The x-axis represents the time of dosing and measurement of antibody response, and the y-axis represents 50% serum neutralizing titer to SARS coronavirus 2. If we begin with those individuals who received 2 doses of vaccine, the primary series, you can see that for both the wild type and the beta variant tested in this trial, that there were robust antibody responses that were most prominent 7 days after dose 2. These began to decline as soon as 1 month after dose 2 and were still lower before dose 3. If you then look at the response after administering the booster, there are at least 3 important observations. Number 1, there is a dramatic increase in the antibody response as measured by GMTs for both the wild-type virus as well as the beta variant at 7 days after dose 3, as well as 1 month after dose 3. Number 2, the difference between the response to the wild type and the beta variant has narrowed, represented by the geometric mean ratio shown at the top. The ratio 1 month after dose 2 is 0.27. 1 month after dose 3, this ratio is 0.73. So we see a narrowing of the geometric mean ratio and therefore narrowing of difference between immune response to the wild-type vaccine virus and the beta variant after the 3rd dose. Number 3, in contrast to the decrease in antibody response seen 7 days after dose 2 to 1 month after dose 2, we actually see an increase in antibody response between 7 days after dose 2 and 1 month after dose 3. So what does all this mean? Our interpretation is that we're seeing a robust immune response that equals or greatly exceeds the response that we've seen after the 2nd dose. This response continues to mature as evidenced by a continuing increase in antibody response at 1 month and narrowing of the difference in geometric mean ratio between the response to the wild type and the beta variant. This bodes well for comparable and perhaps improved protection after a 3rd Pfizer-BioNTech vaccine dose. Again, on the right-hand side of the graphs, these observations are recapitulated and perhaps even more important in the 65 to 85-year-olds. Why? Responses after the 2nd dose of vaccine tended to be lower and decayed more rapidly than in younger adults. But look what happens after the 3rd dose. Higher antibody response are seen 7 days and 1 month after dose 3 compared to those after the 2nd dose, and closely rival those seen in younger adults. There is again narrowing of the GMR between wild type and beta variant and an increase in response over time. This suggests a significant immunologic benefit of a booster dose of the vaccine that is likely to confer similar or perhaps better protection than that provided by the 2nd dose. This information was published in the New England Journal of Medicine this week. Now, of course, it's important to know, does this apply to the Delta variant since that's the variant of current concern? I'm pleased to report the post-dose 3 Pfizer-BioNTech GMTs indicate a substantial boost to the Delta variant similar to that seen with wild type. This information is also included in the New England Journal of Medicine publication. Here we've represented for you the responses 1 month after dose 2 compared to 1 month after dose 3 with a similar scheme as shown on the prior slide. Younger adults on the left and older adults on the right. We again see a dramatic increase in immune response after the 3rd dose as measured by virus neutralizing GMTs to both wild-type virus and the Delta variant, and a narrowing of the GMR point estimates as shown at the top after the third dose. Note that this narrowing of response is most prominent in the older age group. This provides further reassurance that a third dose of vaccine is likely to provide immunologic benefit, restoring and perhaps improving protection against the Delta variant. Given the observations I shared with you earlier about lack of immunologic escape for variants tested to date after 2 doses, these observations inspire optimism about the potential for a high level of protection against current and future variants after a third vaccine dose. So what about reactions seen in phase 1? In the phase 1 cohorts of younger and older adults, the evidence was reassuring that local reactions by maximum severity within 7 days of the third dose, the bottom panel, were similar to those after dose 2, the top panel. The local reactogenicity captured by eDiary revealed no redness or swelling and comparable pain. Also, systemic events by maximum severity within 7 days after the third dose were similar after dose 3 compared to dose 2. We have found fever and chills to be the most discriminating common reactions. In the phase 1 cohorts, comparable levels of fever and a comparable level of chills were seen after dose 3 compared to dose 2. Other reactions were also comparable. This safety information, coupled with the preceding immune response data, gave us confidence that we could move forward into the expanded cohort. So let me now summarize for you the phase 3 portion of this booster study. To begin, I will describe for you how this phase 3 study was designed by Pfizer and approved by the FDA to support a booster dose indication in individuals 16 years of age and older. This FDA-approved approach is based on meeting predefined safety and immune response criteria in the 18 to 55-year-old age group with extrapolation to the full age range, 16 years of age and above. So what is the basis for extrapolation of phase 3 third dose data to 16 to 17 and greater than 55-year-olds? The FDA immunogenicity requirement is outlined in the text shown and referenced by the footnote. It reads, studies may be conducted in a single age group, for example, adults 18 to 55 years of age, with extrapolation of results to other age groups for which the prototype vaccine has been authorized. Meeting this requirement was judged by CBER as sufficient to submit immunologic data for a supplemental licensure of the Pfizer-BioNTech vaccine third dose. Regarding extrapolation of safety to the full age range, a few observations are pertinent. For 16 to 17-year-olds, similar reactions in this age group to 18 to 55-year-olds after 2 doses predicts that reactions would also be similar after the third dose. For adults over 55 years of age, local reactions and systemic events in participants greater than 55 years after dose 2 were lower than those seen in younger adults. This predicts lower reactions after the third dose in individuals greater than 55 years of age based on the favorable or better reactogenicity profile seen after the third dose compared to the second dose in 18 to 55-year-olds, data that I'll be sharing with you shortly. Now, to interpret these results in the context of what we're seeking today, it's important to understand the FDA immunogenicity criteria for a booster dose. The FDA guidance specifies that the booster dose must be adequately powered to demonstrate that the immune responses induced by the booster dose, serum neutralizing titers against SARS coronavirus 2, as measured by seroresponse rates and GMTs, are statistically non-inferior compared to those elicited by the vaccine in the primary series. So how do we do that? The success criteria include demonstration of non-inferiority margins of -10% for seroresponse rates and 1.5-fold for GMTs. Based on consultations with CBER, these criteria are also considered sufficient to support licensure of a booster following full approval of the primary series. This table shows the demographics of subjects receiving the third dose. These demographics are representative of 18 to 55-year-olds in the parent study. Note that we have a balanced representation across gender, races, and ethnicity. Over 50% of individuals had comorbidities as measured by the Charlson Comorbidity Index. The age at vaccination was approximately 41. The time from dose 2 to the booster was close to 7 months, with a minimum of approximately 5 months.
Your microphone has been turned on.
All right, Pfizer, you're back connected.
Okay, thank you. Let me maybe start a little bit back to make sure that everybody gets to hear what I had to say. So this table shows the demographics of subjects receiving the third dose. These demographics are representative of 18 to 55-year-olds in the parent study. Now that we have a balanced representation across gender, races, note that we have a balanced representation across gender, races, and ethnicity. Over 50% of individuals had comorbidities as measured by the Charlson Comorbidity Index. The age at vaccination was approximately 41. The time from dose 2 to the booster was close to 7 months, with a minimum of approximately 5 months and a maximum of 8 months since the 2-dose series. So let's look at the immune response data. Recall that the study needed to meet 2 immunologic criteria for non-inferiority based on comparison of geometric mean virus neutralization titers and seroresponse after the third dose to those responses seen after the second dose. The geometric mean ratio of neutralizing titers non-inferiority criterion post-dose 3 compared to post-dose 2 was met, with titers after the third dose approximately 3-fold higher than those seen after the second dose. This table shows SARS coronavirus 2 neutralization titers in 210 individuals, looking at 1 month post-dose 3 compared to the GMTs after dose 2. The GMR is the ratio of these responses. To declare success, the lower bound of the confidence interval for the GMT on the right side of the table needed to be above 0.67 or 2/3. We see that the lower bound greatly exceeds the success criteria at 2.76, with a GMR point estimate indicating responses were 3-fold higher after the booster dose compared to responses after dose 2. Hence, this meets not only the non-inferiority criteria, but indicates that the virus neutralization responses seen after the third dose are consistent with phase 1 results and greatly exceed and are statistically greater than those seen after the second dose. This figure demonstrates graphically the SARS coronavirus 2 neutralization GMTs with relationship to dose. GMTs shown are based on the number of subjects with valid results at each time point, while the non-inferiority analysis for the GMT ratio shown on the prior slide are based on subjects who had valid results at both 1 month post-dose 2 and 1 month post-booster. Time and doses are shown on the x-axis, 50% neutralizing GMTs on the y-axis. Results are consistent with those seen in the phase 1 study. Neutralizing GMTs rise to protective levels after the second dose, followed by a drop prior to the third dose. By 7 days after dose 3, observed virus neutralization GMTs are nearly double, and by 1 month are triple those achieved after the second dose. These results indicate that a third dose is likely to begin conferring benefit shortly after administration. Non-inferiority of the booster dose was also demonstrated based on proportion of subjects with a seroresponse meeting the second immune response licensure criterion. Seroresponse is defined as achieving a greater than or equal to 4-fold rise from baseline before dose 1. In this population of 198 individuals, the 1 month post-booster response was 99.5% after dose 3 versus 98% after dose 2, when both were compared to baseline. This yielded a 1.5-fold greater response after the booster with a lower bound of the confidence interval of minus 0.7%, well above the minus 10% required. Non-inferiority was also confirmed based on an FDA-defined alternative analysis. We were asked by the FDA in a post-hoc analysis to compare pre-booster versus post-booster seroresponse. And you can see that with this analysis in 179 individuals, the seroresponse rate was 93.9% post-dose 3 versus 97.8% post-dose 2, again meeting the minus 10% non-inferiority criteria with a percentage of the lower confidence interval being minus 8.2%. So, both the pre-specified GMT and seroresponse results, as well as the post-hoc alternative seroresponse rates, satisfied licensure criteria for a booster dose, with neutralization GMTs greatly exceeding those seen after dose 2. Now I want to share with you the safety data that supports a booster dose. Follow-up time for the booster dose study is shown here. Total exposure from booster vaccination to the data cutoff date was a mean of...
Could you please wrap up pretty soon where you're running out of time?
All right. Let me get through the safety information. I thought we had 45 minutes. Are we running close to that?
You are.
Okay. We'll move quickly through this. Okay, follow-up time for the booster dose study is shown here. Total exposure from booster vaccination to the data cutoff date was a mean of 2.7 months and a median of 2.6 months with the ranges shown. And the total exposure from dose 2 to the cutoff date, so including both exposure post-dose 2 as well as that post-dose 3, was a mean of 9.4 months and a median of 9.5 months. So let's look at the reactions solicited by eDiary after the booster dose compared to reactions after dose 2. Local reactions after dose 3 were comparable to those seen after dose 2. Reactions after dose 3 are in the bottom panel, dose 2 in the top panel, and I think you can see these recapitulated results that we saw in phase 1. This provides reassurance of comparable local reactions with the booster dose. Likewise, systemic events by maximum severity within 7 days of the third dose are similar to post-dose 2. Again, the same scheme, dose 3 in the bottom, dose 2 in the top panel. And I again draw your attention particularly to fever and chills, where in this larger data set you can see that if anything, the fever point estimate is lower than that seen for fever after the second dose in this cohort of 18 to 55-year-olds. Reported chills are also lower and other reactions are comparable to those seen after the second dose. This provides reassurance that the eDiary reactogenicity profile after a third dose is similar or perhaps even better than that seen after the second dose. Adverse events by system organ class occurring greater than 1% of participants with 1 month post-dose third dose were less than those post-dose 2 in the parent study, with the exception of lymphadenopathy. Adverse events after dose 3 are shown in dark blue bars, adverse events after dose 2, light blue bars. At the top of the graphic chart, blood and lymphatic disorders at 5.2% is entirely represented by axillary lymphadenopathy. By comparison, after dose 2, 0.5% of the 0.6% in this category is also represented by lymphadenopathy. Generally, lymphadenopathy after dose 3 was mild, self-limited, and resolved. Lymphadenopathy includes 1 individual whose lymph node enlargement was judged severe by the investigator due to reported prevention of arm movement. It lasted for 5 days and resolved. For reactions other than blood and lymphatic disorders as shown on this graphic, the incidence of adverse events was typically lower or comparable after dose 3. These AE findings are reassuring regarding the safety profile of the vaccine. There were no SAEs or withdrawals due to SAEs in the 1-month period after the third dose. Only 1 serious adverse event was observed through the median of 2.6 months of follow-up at the time of data cutoff, which was assessed as unrelated to the vaccine. This was a myocardial infarction reported 62 days after dose 3 by an individual in their 40s. The event was considered unrelated to study intervention by the investigator. This individual had a medical history pertinent to the etiology of the myocardial infarction, and the cardiac event was considered secondary to stimulant abuse. The myocardial infarction was reported as recovered or resolved without sequelae within 1 day of onset following treatment. Details of this case are included in the briefing document. You may recall a version of this slide from the emergency use authorization, which has been annotated somewhat to reflect the ongoing work that is done. You can see the nature of the pharmacovigilance that we are conducting. Pharmacovigilance activities are a critical component of activities relating to the detection, assessment, understanding, and prevention of risk. Pfizer has been conducting robust pharmacovigilance activities and collaborating with regulators and international groups. We will continue to look for rare adverse events such as myocarditis, anaphylaxis, as well as other adverse events of special interest. The current approach to pharmacovigilance has been valuable in detecting and assessing rare events and risks.
You're
and we will continue
at the end of your time, Bill.
All right. The evidence to date supports a positive risk-benefit for the Pfizer BNT vaccine. Let's go to the next slide, please.
We really you're really
right.
over your time, and FDA has to be able to speak.
Right, I understand. So let me just recapitulate. You've already had a chance. If we go to the next slide, please. Information has been shared with you earlier. As you heard earlier from this morning, a third booster dose restored high level of effectiveness for preventing both infection and severe COVID-19. And this table represents... All right. So I think that the point is that we obviously have seen a dramatic fold reduction by 11-fold for infection and 15.5-fold for severe infection that we believe a booster dose can restore. And with that, I will turn this over to Donna Boyce to wrap up.
Well, I think we've already had a wrap up. So thank you both very much. We will have a Q&A session later on in which you all will be able to participate. Let's go on now and hear the FDA presentation from Dr. Joo-Heen Lee. Dr. Lee, please.
Good morning, everyone. I am Dr. Joo-Heen Lee. I'm a medical officer at the Office of Vaccines and Research and Review within the Center for Biologics Evaluation and Research at the FDA. So here's an overview of the presentation today. I'd like to just mention that these slides are a collective effort of many members of the Office of Vaccines. So to quickly go through this, on August 23rd, 2021, FDA approved the BNT162b2 vaccine under the proprietary name of Comirnaty for active immunization to prevent coronavirus disease 2019 caused by SARS-CoV-2 in individuals 16 years of age and older. It's currently the only vaccine or medical product that is FDA approved for the prevention of COVID-19. And the BLA supplement being discussed today is intended to support approval for booster administration of Comirnaty approximately 6 months following the primary series. So I will start with the regulatory background with some key dates. In April 2020, starting on the left, the pivotal parent study C4591001 enrolled the first patient. In December 2020, an EOA was issued for the primary series in individuals 16 years of age and above. And in May 2021, this was extended to individuals 12 years of age and above. And on August 13, an EOA was issued for a third primary series dose for immunocompromised individuals. In August, as I previously mentioned, on the 23rd, we licensed the primary series of Comirnaty in individuals 16 years of age and above. So let me go through the booster study design. As previously mentioned, this starts with the parent study, during which over 44,000 individuals were randomized to receive Comirnaty or saline placebo, given two doses given 3 weeks apart. Now, after serial unblinding, a number of individuals received a booster dose. First, in phase 1, where 23 adults received their booster dose approximately 8.2 to 8.4 months after dose 2. And in 306 individuals from the phase 2-3 portion who received it in a median of 6.8 months after dose 2. Safety data were collected uniformly as shown in the boxes below, with solicited, unsolicited, serious adverse events, and deaths and serious adverse events that were deemed related to be collected for out to 2 years after dose 2. Now, I'll point out that the data to be discussed today will be from a subset of the 44,000, and so for the first 2 doses. We'll skip over. So just to give you an overview of the demographic profile for the booster dose participants, the phase 1 participants were very homogeneous, and as you can see on the bottom bar or section below, none were obese, none had comorbidities or history of SARS-CoV-2 exposure pre-dose 1. And the homogeneity is largely a function of the eligibility criteria for the study at phase 1 in development. And in the last column, you see, as you've seen before, the profile for participants in phase 2 and 3. And you see some greater diversity in race, predominantly white at 81%, and some with history of SARS-CoV exposure at 3.6%. Any of the comorbidities deemed to confer increased risk for severe COVID, excluding obesity, was at 18.3% and approximately 40% with obesity. So we'll move on to the immunogenicity results. So the primary immunogenicity objective was to demonstrate non-inferiority of neutralizing antibody geometric mean titers against the reference or the wild-type SARS-CoV-2 strain USA Washington 1-like. Washington 1, I'm sorry, which is Wuhan-like. It was measured after the booster dose and compared to after the 2-dose primary series in the same individuals. And you can see in the pictorial above the 4 time points of interest that will be discussed in the subsequent slides. Another point to make is that the immunogenicity data were obtained using a validated virus microneutralization assay to quantify GMTs. So there are 2 co-primary immunogenicity endpoints for which non-inferiority was assessed. The first is the ratio of GMTs of SARS-CoV-2 neutralizing titers against the wild-type virus strain. And you can see here the ratio post-booster dose over post-dose 2. And here on the right are the criteria for non-inferiority. Lower bound, the 2-sided 97.5 confidence interval exceeding 0.67, and the point estimate of the GMT ratio of at least 0.8. The second immunogenicity endpoint that was analyzed for non-inferiority was the percentage difference of seroresponse at 1 month post-booster dose and at 1 month post-dose 2. Seroresponse is defined as at least a 4-fold rise, and this depends on a baseline measurement that is under the lower limits of quantification, and a post-vaccination measure that is at least 4 times that to be considered a seroresponse. And so what was being evaluated here, as pre-specified, was the percentage of individuals with a 4-fold rise from pre-dose 1 to 1 month post-booster dose, minus percentage of those with a 4-fold rise from pre-dose 1 to 1 month post-dose 2. And non-inferiority was declared based on the following criterion, with a lower bound for the difference in the percentage of seroresponders at these 2 time points being greater than negative 10%. So here are the immunogenicity analysis populations. Let me see here if I can get the little arrow. So starting at the top, is the 306 individuals who comprise the all available immunogenicity population, and those were those who received BNT162b2 at 30 micrograms. And in the process of reaching the evaluable immunogenicity population, 44 were excluded primarily due to important protocol deviations. And then the number further slightly decreased to 234 because of the additional criteria of having no evidence of infection from dose 1 to 1 month after booster dose. And in the rectangle on the bottom is the definition of what was considered without evidence of infection. Okay. So here the slide shows the GMPs against the reference strain in the dose 3 booster evaluable immunogenicity population without evidence of infection. And on the y-axis on a log scale are the GMPs. And along from left to right, you go from pre-dose 1, 1 month post-dose 2, right before post-dose, right before booster dose, I'm sorry, and then 1 month post-booster dose. And so you can see the trend that has been previously pointed out with the titers increasing dramatically after post-dose 2 with some waning within the 6 months prior to the booster dose administration, and a rise several significantly greater than that 1 month post-booster dose. So here I show the non-inferiority analysis based on the GMT ratios against the reference strain. And boxed in blue is the primary analysis population, which are the 210 individuals who were qualified to be in the evaluable immunogenicity population with no evidence of infection. And I'll point you to the rightmost column, which is the GMT ratio that we looked at comparing post-dose 3 to post-dose 2. The point estimate of 3.29 and a lower bound of 2.76 was clearly above the non-inferiority criterion that was mentioned before, which is the point estimate of being greater than or at least 0.8 and a lower bound of greater than 0.67. And here you see the pre-specified non-inferiority analysis based on seroresponse. And the rightmost column shows the endpoint. It's the difference in seroresponse between 1 month after booster and 1 month after dose 2. And the difference is at 1.5% with a lower bound of negative 0.7%. So this met the criterion set with respect to the lower bound of being greater than negative 10%. And as mentioned previously by Dr. Gruber, we did ask for an alternative or complementary analysis for which we asked them to define seroresponse using pre-booster rather than pre-dose 1 to define the seroresponders or the difference in seroresponse between 1 month after booster dose and 1 month after dose 2. And as you can see here, the numbers are different, but these findings do not challenge the previous, the data from this previous slide, which shows that they've achieved non-inferior immunogenicity for the 2 co-primary endpoints. Okay, so here I'll go through the exploratory phase 1 analysis of virus neutralization titers against the Delta variant, as well as against the wild type or reference strain. As previously mentioned, the assay that was used to produce these data comes from a 50% plaque reduction neutralization test. And this was done in 23 participants against the reference USA strain and the Delta variant. And These titers were assessed in sera 1 month after dose 2 and 1 month after dose 3. And in the box in the middle of the slide are some considerations that this PRNT assay is not the same as the validated microneutralization assay for which we have immunogenicity data, which was presented in the preceding slides. It is well accepted and there was standardization, but it's not validated, and it was used for exploratory purposes. And the relative sensitivity for the two strains currently are unknown. So here are the results. On the columns are divided. You see on the left column Delta variant GMTs, wild type GMTs with confidence intervals. I have presented the 11, 18 to 55-year-olds on top of the older adults. And you see post-dose 2 here versus post-booster dose. So these numbers have been presented in the previous presentation. This is just arranged slightly differently, but you can see that neutralizing titers against the Delta variant and the wild type are present and measurable in both populations or age groups. And you see the difference between post-dose 2 and post-dose 3 uniformly across the two strains and across the age groups as well. Now, another post-hoc analysis that we requested from Pfizer had to do with breakthrough infections, particularly those that were detected during the Delta surge. And so what we asked of Pfizer was to provide numbers of protocol-specified COVID-19 cases that were accrued during the early July and end of August in participants 16 years of age and above. And on the left, you see we are looking at participants who completed the 2-dose vaccination series early in the study, or the parent study. So these refer to individuals who were originally randomized to BNT162b2. And among these almost 19,000 individuals, there were 70.3 cases per 1,000 person years. That's the incidence calculation that Pfizer provided. 3 were severe. This was collected over a period of 9.8 months post-dose 2. And on the right, you see we're considering the individuals who completed the 2-dose vaccination series later in the study. In other words, those who were originally randomized to placebo and then crossed over to the active vaccination group. Among these almost 18,000 individuals, there was an incidence rate of 51.6 cases per 1,000 person years. The mean duration was slightly less, as expected, at 4.7 months post-dose 2. So the data here suggests that the incidence of breakthrough infections appear to be higher in those who completed the vaccination series early versus those who completed it later. So in order to contextualize this delta in incidence, we did the following, we made the following calculations. Bubble number 1 on the left. You see the ratio that we set at the incidence rate among late vaccinees versus early vaccinees, and that came out to 0.73. And so the purpose of this calculation is to try to translate the relative breakthrough rate to vaccine efficacy. So we took this ratio of 0.73, and for each of the assumed efficacy values shown in the table below, among the placebo crossover group, we calculated the impact of this differential in breakthrough cases on the corresponding efficacy among those who are vaccinated earlier. So let me take you through one. If we assume that the efficacy of the vaccine, let's say for severe disease in placebo crossover recipients vaccinated later, then the differential in the incidence rate that was determined during the Delta surge would translate to approximately a 4% reduction in vaccine efficacy in those vaccinated earlier. Now, continuing on, so this is not actually during the Delta surge, but pre-Delta surge. If you look at the numbers, we consider the incidence of COVID-19 among early vaccinees from the evaluable efficacy population before the Delta surge occurred. And the case rate, or the incident rate, was at 12.6 cases per 1,000 person years. And when you looked at the later vaccinees, the placebo crossovers, in this case before Delta, the incidence was actually higher, at 43.4 cases per 1,000 person years. So the takeaway message is the data are complicated, and the limitations of the analysis are as follows. The parent study was not designed to assess the relative vaccine efficacy of the crossover group versus the original vaccinees. And therefore, this analysis is exploratory in nature, but still we thought would be quite informative or important to consider. In addition, the open label nature of the booster dose may have introduced confounding factors that include behavioral changes that bias the results. And of course, as mentioned previously, there are confounders that we are just not aware of at this time. Okay. So going on to the safety results. As mentioned previously, here the mean length of safety follow-up in the booster recipients in the phase 1 portion and the phase 2-3 portion were basically the same at 2.7 months and 2.6 months respectively. Here I am showing you the local reactogenicity data across doses, dose 1 and dose 2 data coming from the reactogenicity subset of vaccinees from the blinded portion or blinded phase of the study with an N of 2899 and 2682, and comparing this with the reactogenicity of those who received booster, the phase 2-3 participants in phase 1. And you can see here that injection pain, site pain continues to be the most common local reaction, and severity tended to be low with only one case, for instance, in the booster recipient. Overall, the data suggests that local reactogenicity does not appear to be enhanced following the booster dose relative to dose 2. Here, this is a busy slide, but so here are the systemic reactogenicity preferred terms that were recorded by eDiary 7 days after each dose. So along here, I've ordered the specific adverse reactions in descending order of frequency. So fatigue is the most common. And here you see the phase 2-3 dose 1 recipients, phase 2-3 dose 2 recipients, and the booster dose in booster dose recipients from the same phase. And fatigue continues to be the most common, and severity does not, the severity of fatigue does not appear to vary significantly from that observed after dose 2. And a similar relationship between all these other commonly reported systemic adverse reactions can be seen between dose 2 and dose 3. Frequency of fever slightly dipped after the 3rd dose, and use of antipyretics and pain medication were comparable after dose 2 as compared to after the booster dose. Okay. So here we're looking at the systemic reactogenicity profile by age strata. So the 289 individuals who submitted e-diary data were 18 to 55. And here this table only includes the individuals in the 65 to 85 year old age strata, and there were 12. And so if you look overall, the order of frequency of systemic reactogenicity is about the same. And it's worth pointing out that severe reactions of any kind in terms of systemic reactogenicity were not reported among these 12 recipients. Fever was also not reported. And the use of antipyretics or pain medication was also less. Now going on to unsolicited adverse events that were monitored 1 month post booster. So here presented in this table are the most common events that occurred in more than 2 participants, or 2 or more participants, I should say. And the one worth pointing out is lymphadenopathy. It occurred in 16 participants with a corresponding frequency of 5.2%. The majority were mild to moderate and they did resolve. All but 1 is reported to be as ongoing at this time. 1, as mentioned previously, was deemed severe due to impact on activity. This occurred 2 days after the booster dose and resolved over 5 days. Considering the time period of booster dose to data cutoff, which is at least 2 months of post-dose 3 follow-up in the 306 participants, there was 1 additional AE of acute myocardial infarction reported as an unrelated SAE. This occurred on day 62 post-booster dose and recovered and resolved. No participants were withdrawn due to adverse events, and among the 306 participants evaluated, there were no cases of anaphylaxis, hypersensitivity, Bell's palsy, appendicitis, or myocarditis, pericarditis. And among the 23 phase 1 booster recipients, there were no AEs that were reported 1 month after booster dose. So finally, I come to my last slide, which is a summary of the data that we reviewed that were submitted to this BLA supplement. So in terms of immunogenicity, success criteria against the reference strain were met for both pre-specified co-primary immunogenicity endpoints, which were the GMT ratio and the difference in seroresponse rates among study participants with no evidence of SARS-CoV-2 infection prior to 1 month after the booster dose. The immunogenicity data to support effectiveness of the booster dose against the Delta variant are limited to exploratory analyses in a small number of participants using an assay, while standardized and with a reference control is not validated to date. In terms of the safety data, from the 306 phase 2-3 booster recipients, there's no evidence that there is increased reactogenicity relative to dose 2. Difficult to reach conclusions about relative reactogenicity by age, or it is difficult to reach any conclusions about the relative reactogenicity by age, as there are only 12 participants, and in the age strata of 65 to 85, the minimum and maximum age range was 65 to 75. Lymphadenopathy was observed more frequently following the booster dose than after the primary series doses. That's worth mentioning. There were no deaths, vaccine-related serious adverse events, or events of myocarditis, pericarditis, anaphylaxis, appendicitis, or Bell's palsy among the 325 booster recipients. And so I am done with my portion.
Thank you very much, It's time for our break. We will break until the open public hearing begins at 12:30 Eastern. So we've got a long 13 or so minute break until the open public hearing. See you back then.